Hi guys, welcome back to the channel. Today we are discussing the APC trial, efficacy, safety of paired sedation and ventilator weaning protocol for the mechanical ventilated patient.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in mechanical ventilated and sedated patient, do spontaneous awakening trials, in addition to the spontaneous breathing trial, reduce the dependence of mechanical ventilation? Design for the trial: multi-center trial, randomized control trial, 1:1 computer-generated block randomization stratification by center, developmental assignment, unblinded due to the pragmatic limitation, intention to treat analysis, power to 80% to detect 25% increase in the primary endpoint with a two-sided significance level of 0.05 based on mean ventilator free rate 12.9 in a pilot study, 20% change in false negative, 5% change in false positive. Setting for the trial for large medical center in the USA, October 2003 to March 2004. Duration of the trial. Population for the trial. Inclusion criteria: adult medical patients expected to receive mechanical ventilator for 12 hours or more. Exclusion criteria: mechanical ventilation lasting longer than 2 weeks, cardiopulmonary arrest, profound neurological deficit, moribund, withdrawal of life support, enrollment in another trial. All new admissions screened according to the enrollment criteria. 1,680 patients, 338 patients randomized. Intervention: spontaneous awakening trial. Process: do sedate for up to 4 hours. Sedatives and analgesics used for the sedation were interfered. Analgesics for pain relief were continued. Criteria for failure were: did not open their eyes to verbal stimulation, sustained anxiety, agitation or pain. Any of SBT failure criteria. Contraindication: indication for deep sedation, active seizure, alcohol withdrawal, ongoing agitation, neuromuscular block, rise intracranial pressure, myocardial infarct in the last 24 hours. If this was not tolerable, sedatives were restarted at the half US rate and titrated back up. Spontaneous breathing trial is successful. Spontaneous awakening trial performed as a control group. Describe. Next slide. Control: spontaneous breathing trial is suitable each morning. Process for breathing for 2 hours on any one of the following: pressure supported ventilation, less than 7 cm of water, continuous positive pressure ventilation, CPAP for the 5 cm of water, T-tube circuit. Criteria for the failure were: tachypnea more than 35 per minute or bradypnea less than 8 per minute, hypoxemia, SpO2 less than 88%, acute mental status change, acute cardiac arrhythmias, any two signs of respiratory distress, tachycardia 130 beats per minute, bradycardia less than 60 beats per minute, accessory muscle use, abdominal paradoxical movement, diaphoresis, marked dyspnea. Contraindication: no spontaneous respiratory effort, inadequate oxygenation, SpO2 less than 88 or FI2 more than 0.5 or sleep more than 8, rise ICP, myocardial infarction in previous 24 hours, agitation, significant vasopressor support, dopamine more than 5 microgram per kg per minute, noradrenaline more than 2 microgram per minute, vasopressin, minineuron. If successful SBT, then clinician had a final decision regarding the extubation. Both groups were sedated the same. Patient target sedation to the level of arousable and comfort deemed clinically appropriate for each patient. Outcome from this: Primary outcome is addition of spontaneous awakening trial assisted weaning from the mechanical ventilation, increase in ventilator free days 14.7 versus 11.6. Secondary outcome significantly faster discharge from ICU, mean days 9.1 versus 12.9. Significantly faster discharge from hospital, median days 14.9 versus 19.2. Trend towards the reduced 28-day mortality 28 versus 35%. Significantly reduced 1-year mortality 44% versus 55%. Significantly reduced duration of coma RASS, mean 2 versus 3. No difference duration in delirium based on CAM-ICU score, median days 2 and versus 2. Complications significantly more frequent self-extubation 10 versus 4. Not significant reduction in frequency of tracheostomy 13% versus 20%. No difference in re-intubation rate even after self-extubation. Subsequent analysis show no long-term physiological or functional differences. Strength of the trial addresses widely applicable topics, pragmatic design, easy to replicate, appropriate randomization, similar baseline characteristics, both demographically and clinically, good follow-up 99%, weakness, potential bias inherent study design, several eligible patients, proportion to the 324 were not enrolled due to the physician refusal. The performance of the study was necessarily unblinded and level of sedation and timing of extubation was at the clinician discretion. Complicated statistical analysis including the bootstrapping was employed due to the unusual distribution of the variable. This makes the interpretation of the study finding more difficult. The mechanism of the observed survival benefit is difficult to explain. Rate of re-intubation and tracheostomy were high. General ability. No surgical patients were included due to their need of continuous anesthesia. Thus, the control group represents common practice. Modern practice target lighter sedation than was common at the time. Author conclusion. Use of so-called wake up and breath protocol that pairs daily spontaneous awakening trial. Interruption of sedatives with a daily spontaneous breathing trial for the management of mechanical ventilated patients in intensive care result better outcomes than current standard approaches and should become a routine practice. Bottom line, the use of spontaneous awakening trials during this trial appears to expedite weaning from the mechanical ventilation, but the study finding may potentially reflect greater than level of over-sedation in the control group or bias toward early extubation in the intervention group. Their use may be associated with a greater risk of self-extubation and increased nursing workload.